Moving on to Chapter 6, I talk all about the central venous pressure. And in this overview, I'm going to talk a little bit about the determinants of the central venous pressure. And so, firstly, the central venous pressure, which is what we measure with a fluid-filled catheter placed usually through the SVC down to the cavo-atrial junction. This pressure that we're using is a surrogate of central venous volume. Remember, pressure and volume are related by compliance, and just for simplicity, I'm going to ignore the impact of caval compliance and say that central venous pressure is what we're measuring as a surrogate of the central venous blood volume. And so if you think of what are the determinants of volume in the thorax, well, it's going to be, if you think of the right atrium as like an eddy in a stream, then the volume in the right atrium is going to be a combination of inflow going into the thorax and thoracic outflow. That's your and so this is your venous return and this is your cardiac function. So if you're pushing a lot of blood into the thorax, your central venous volume, but at the same time you're pumping a lot of it out, well then your central venous volume may remain the same or actually even decrease. Conversely, if you have a little bit of inflow to the central venous space and at the same time your heart's unable to pump it out, well then oddly enough, your central venous blood volume and therefore your central venous pressure may actually increase. So what is this? Well, this is the Campbell analysis. This is the Gaytan analysis. So this increase of this increased flow or this increased volume into the right atrium can be depicted here by the Gaytan diagram. So again, this is your venous return curve. This is your mean systemic filling pressure here on the x-axis. And this is determined by the stressed volume over your venous compliance. So the higher your stressed volume is, which is a marker of your volume status, whether you're hypo-euvolemic or hypervolemic. The stressed volume determines this pressure head. This is the pressure head for a return back to the right heart. So if I were to give this patient a few liters of crystalloid and increase their volume status or make them hypervolemic, I will increase their stressed volume, I will shift their venous return curve rightwards, and therefore for any given downstream pressure, which is your right atrial pressure in this situation, remember this is the pressure up here, moving in this direction would be your mean systemic pressure, and then your downstream pressure will be your right atrial pressure here. For this venous return curve, there's a greater flow for a given right atrial pressure. Similarly, if you were to lower your mean systemic filling pressure, say by going into hypovolemic shock, well then your venous return curve would shift leftwards and there'd be less venous flow for any given right atrial pressure. But at the same time you have to take into consideration what is coming out of the central space, and that is determined by the Frank-Starling mechanism. So in this patient with this curve, the higher the right atrial pressure, the greater the output, and this is induced by stretch-induced calcium sensitivity. In this patient whose cardiac function curve is shifted up and to the left, increased cardiac function, well, they have a greater outflow for the same right atrial pressures. This patient whose heart cannot pump blood out of the central space as well, then this patient will have less outflow for a given right atrial pressure. And so therefore you can see that the volume in the right atrial pressure and therefore the blood volume in the right atrium and therefore your right atrial pressure or your central venous pressure is determined by the relative inflow, your venous return curve, and the relative outflow, your cardiac function curve. So putting this together, you can imagine a patient like this one here who will say, for argument's sake, this is a euvolemic venous return curve and this is a normal cardiac function curve. This patient has this right atrial pressure for this cardiac output. Okay, the right atrial pressure, even though it's on the x-axis, the right atrial pressure is not an independent variable. So there's this tendency in our brains to think that if it's a variable on the abscissa, then it is an independent variable. But the right atrial pressure in the Gaytan analysis is not independent. What the truly independent variable is the mean systemic filling pressure. That's what you're altering, shifting this curve left and right. Similarly, for the cardiac function curve, shifting the cardiac function curve up and down is really the independent variable changing your cardiac function, and then the right atrial pressure is an innocent bystander. So if you were to take a patient and watch this arrow, increase their venous return, say by giving them a ton of fluid, well, you may increase their mean systemic filling pressure. You've given them a bunch of crystalloid, and so now their venous return curve shifts rightward. But if they simultaneously increase the outflow, watch this arrow, if they simultaneously increase the outflow, well, it's going to be a wash. They'll have the same central venous volume and therefore the same central venous pressure. So two different patients, one's hypervolemic, same central venous pressure, and that's because you can only interpret your central venous pressure when you know your cardiac output, or at least your cardiac function. Similarly, watch the inflow arrow. If you were to make somebody hypovolemic, so they have much less venous return, you shift their venous return curve leftwards, but you concomitantly reduce their forward flow by giving them, say, a poor heart. Well, look, all these patients, hyper, euvolemic, and hypovolemic, all have the same central venous pressure, and you have to understand, therefore, that the central venous pressure is not a marker of your volume status. And Sheldon Magner, who uses the analogy that you have to think of the CVP as like your pH. And your pH varies as a function of multiple physiological determinants, much like the CVP does. So asking what the patient's volume status is from their CVP would be like giving you the patient's pH and asking you for their lactate concentration. It doesn't make sense. Lactate certainly plays a role in a patient's pH, as volume status plays a role in the patient's central venous pressure. Welcome to an overview of my final chapter, and that's chapter 8, or dynamic means of cardiovascular monitoring. So what we're trying to get at with dynamic means of cardiovascular monitoring is determining whether somebody is volume responsive. And what I want to talk about in this slide is the difference between volume responsive and volume status, which people seem to use interchangeably and inappropriately. So if you increase your right atrial pressure, and that results in an increase in output, then you are volume responsive. So in this patient, I've sort of delineated in this green area that if they're on this portion of their Starling curve, increasing the right atrial pressure by, say, increasing their venous return, will augment blood flow. And in this portion in red here, this is the flat portion of the Starling curve. Giving more fluid on the flat portion here will not augment blood flow and only increase filling pressure with likely detrimental outcomes. So how do we know when the patient is on the ascending portion of the curve? Because you can have a patient like this one who, with their venous return curve shifted leftward, this patient could actually be hypovolemic, but they're actually operating on the flat portion of their cardiac function curve because of their diminished cardiac function. So this patient could be hypovolemic but volume not responsive. So you can see that there can be a considerable distinction between volume responsiveness and volume status.